Are the ingredients we need in a program to prevent these ACL tears, some of which Dr. Collins showed you were extremely scary experiences. I think most of you probably know the most cheating possible quarterback in the NFL. Who would that be? Allegedly. What school did he go to, by the way? That school up north there? Never mind. But anyway, I think most of you know he ended up with an infection. So he left Boston, went back to Southern California, had his ACL reconstructed, and ended up with a really nasty infection that set him back quite a ways. And so, yeah, these are realities that you all face as clinicians, scary realities. So this is Michael Owen tearing his ACL. What you see is, again, this combination, this gross flat foot, starts out with a relatively straight knee. His trunk comes over, his femur rotates in, his knee collapses, and he pops his ACL. Totally different athlete, different kind of athlete, totally different kind of sport, very common mechanism. Flat foot, landing on a relatively straight knee with the trunk coming over. So what does this tell us? If we want to prevent one of these injuries from happening, let's make sure the athlete doesn't land on a flat foot. A flat foot means a high ground reaction force. So that's a key component of this. The athlete has a relatively straight knee, so we want that knee flexed, the knee and the hip flexed. We want that athlete not to allow a lot of lateral movement of his or her trunk, so he or she needs to be in control of that hip and trunk complex using a dynamic core with the foot with most, if not all the weight on a single foot. So from a mechanism standpoint, we want them not to be flat-footed. We want to be on the ball of their foot with their hip and their knee flexed, with their center of mass positioned directly over the plantar base of their foot, with their knee and hip in a stable, non-valgus configuration. If we can do that, we can reduce the risk of an ACL tear. And we've demonstrated this in the lab, and we've demonstrated using the same techniques in the field, and we show we can reduce the risk of this. It's interesting, we've talked a little bit about this, but I think Nancy Cummings tomorrow is going to talk a lot more about it. Female athletes from a primary standpoint are at significantly greater risk. It is very sport dependent. But if you look across, for example, skill levels, we did this study several years ago. Skill levels have nothing to do with this. I've consulted with many D1 women's basketball teams, and it seems to me I see that internal hip rotation valgus sign in just as many D1 female basketball players as I do in junior high school and high school kids. I don't know, you would have think they would have been selected out by that point, but it's just very common, and this sex disparity within the same sport is very, very consistent across levels. So it's not a skill level thing. The female aspect of this is enormous. Our latest estimates are well over $1 billion just due to the sex effect in primary. There's lots of general theories on how this occurs. Extrinsic factors, there is some data that shoe and surface play a role. There is some data that hormonal factors play a role. I could talk for a few hours just on that. Structural, there are structural aspects, hue angle, notch width, the tibial slope, those all play roles. Where we're going to focus most of our attention is these, because these are systematic, reliably adaptable, modifiable, and have been shown to reduce risk. So again, you'd have to look at that mechanism to see how this occurs, and then you have to look for that athlete. You have to do simple screening tests. Again, What you see in this athlete, she's had her ACL reconstructed, she has a post-op brace on, and look at the mechanics moving down the court. She's at risk. This young lady was a starting point guard in Division I basketball. She tore her ACL, and they put this in the paper saying, gee, look, we lost our starting point guard. But she was doing that well before the injury occurred. So we talked about these parallel neuromuscular imbalances. We're going to talk more about them in the lab coming up in about 10 minutes where we start moving. So, and then we've talked about addressing the mechanism, biomechanics and technique, a lot of education, power training, powering up the posterior chain, a lot of single leg balance symmetry work and dynamic core stability on the foot. And basically what we do is, and we're going to talk about these, developing the biomechanics, using the plyometrics, incorporating the core stability and strength training as well. Just as an idea, so what are the components of a successful primary ACL prevention program? I'll give you the punchline right here. Plyometrics and biofeedback. It's kind of equivocal whether strength training is needed or not. And that's, we've done it now. So this is all based on multiple meta-analyses. We've done these meta-analyses 4 times now. And basically every single time it says plyometrics needs to be incorporated, but it has to be accompanied with a lot of visual, verbal biofeedback. That's what works. So warm-ups, so slow static stretching prior to a game, does that prevent an ACL injury? No, it does not prevent an ACL injury. And the data meta-analyses show that. So slow static stretching is good. It's good for several things, but it's not good for preventing a ligament sprain or rupture. What slow static stretching may do is it may reduce the risk of a muscle muscle strain. So muscular tendinous effects, maybe slow static stretching may be helpful. For ligament injury prevention, no. So if you're going to do slow static stretching, slow static stretching actually decreases, it's been shown, the nerve firing patterns. It's a slow mechanism. You want things to speed up. So if you're going to do slow static stretching, not necessarily to prevent an ACL, not necessarily before a high intensity match. If we do training orders, plyometrics needs to be done first because you have to be fresh. It's very high intensity, it's anaerobic activity. You want to do that first, and then you're going to get into functional core training, then afterwards resistance training. So plyometric principles, basically what we want to do is stretch the muscle prior to contracting it in order to get more force generation, more force absorption out of it. So the goal is to reduce that amortization phase to make your movement faster and more powerful. And by doing that, if you do it properly with good biofeedback, you're going to really be forced to recruit the posterior chain, especially the glutes and hamstrings, that are both agonists of the ACL. They both take force off of the ACL. So training principles, supervision and analysis. The one thing we never want to do with prevention training is hurt somebody. So we obviously need a lot of supervision. We do this. We've trained several thousands of kids now. I think maybe the worst injury we had was one of my high-level strength trainers had a high school tight end, was about 6'5", 240, hopping onto a BOSU, and he sprained his ankle. We've had very, very little injuries. So plyometrics does not have to be dangerous. Plyometrics is just repeated jumping, just repeated jump, which forces a muscle to stretch prior to contraction. It doesn't have to be hurdle jumping. It is not aerobic. It does not need to be the maximum number of jumps, and it's not easy, but if you do it well, the athletes will like to do it. The athletic positioning is very important. That linebacker position or hockey goalie position on the balls of the feet. Again, balls of the feet. You want to teach an athlete to roll the foot, don't land flat-footed. This is how ACL injuries, watch the videos. ACL injury happens like this. Flat foot, slap flat foot, high ground reaction force, relatively straight knee with the trunk moving around. So body in good control, that linebacker type of position, activating the musculature, not hanging off of the joints. Using the feet to dissipate force, simply telling someone to land with less noise can reduce landing forces by body weights at a time. Flexing the body, getting ready for the next jump. The good thing is a lot of the same things strength coaches and track coaches use to enhance performance, enhance vertical jump, are going to increase or reduce the risk of an ACL injury. Increasing intensity. As soon as an athlete is able to master a plyometric, you move it to another level, but there's lots of ways to modify intensity through arm position, through eyes open, eyes closed, reducing speed, adding unanticipated movements. We do a lot of perturbation, unanticipated movements with our training. We try to take it to the sport level as close as possible and then adding in as many sport-specific skills. This is a D1 soccer player who had a terrible internal rotation hip valgus, and we just kept working on her in frontal and sagittal plane, getting her to flex down and not allowing that hip internal rotation and knee valgus drop. Footwear, good support. You'll see out in our labs, we're on a 2 3/8 inch Mondo floor there. Those are the type of training surfaces you want. I have gone out and consulted where guys are doing these strength camps, you know, bigger, faster, stronger type camps, and they're doing drops off of meter-high boxes going into vertical jumps on concrete, and these kids have anterior knee pain. Again, what we want to do is no harm for sure. So a lot of this is just common sense. Basically this is the first meta-analysis that we did, and basically what we showed is across the board a favorable effect by about 62%. What we did is show that these do work and that plyometric training and biomechanical analysis and technique were common components of all those that did work. Balance training alone, just balancing on a wobble board or a BOSU or if it's just a balance training alone, it's not effective, except maybe in males. There was an Italian study by Carafa. They just put about a foot square of plywood and put a 2x4 underneath it, wobbled on it for 4 weeks, and reduced the risk of ACLs by about 80%. It was again done in males, in amateur football players. That's not been corroborated since. But I should say balance training is a common component to other very successful programs. So I'm going to argue if neuromuscular training we can use the training to show the increased control of the joint and reduce the risk of ACL injury. The mechanisms underlying risk are in large part neuromuscular in nature. Yes, there are other inputs. There are anatomic inputs. There may be hormonal inputs in females. There likely are. However, if we can use neuromuscular training, show the changes in these neuromuscular high-risk patterns, then reduce the risk of an ACL, in large part these are neuromuscular in nature and they're modifiable, and that is the good news in all this. So knee joint control, common components. What we see is they reduce the risk of ACL, their potential for combined use. Again, plyometrics and biofeedback are crucial. Balance and strength training may be helpful, but they may not be required in an ACL prevention program. So again, balance training alone was not as effective. It's probably better when combined with other techniques. And again, very high level athlete, but landing on that flat foot with the trunk out of position is going to lead to disaster. So the training has been shown to reduce those valgus stresses, increase core stability, especially on a single foot. This is a series of studies we did with a group at Yale where we showed that athletes that don't control their core well have a greater risk of ACL injury. And at this point, we're going to go ahead and take off to the lab. What you will have is a 1, a 2, or a 3. Let's get it separated. We should have a third in each. You're going to